This lesson is on endometrial cancer or endometrial carcinoma. So in this lesson, we're going to talk about risk factors for getting this type of cancer. We're also going to talk about some of the pathophysiology behind why it occurs. And then we're going to talk about the signs and symptoms, how it's diagnosed, and how it's treated. So endometrial cancer is also known as corpus cancer. It is a cancer of the endometrium. The endometrium is actually the inner lining of the uterus, and the uterus itself is a reproductive organ. And this type of cancer arises from malignant cells of glands of the endometrium. And what happens is these cells end up spreading into other parts of the uterus and beyond the uterus as well. We're going to get into more specific details later on in this lesson. Endometrial cancer is actually the most common gynecological cancer in the developed world. And the lifetime risk of females getting endometrial cancer is 2 to 3%. And the mean age of onset of endometrial cancer is 62 years old. So we're going to see this most commonly in postmenopausal individuals. And we're going to talk about why that is later on in this lesson. Now, to have a better understanding of endometrial cancer, it's best to know some of the anatomy. So let's briefly talk about the anatomy of the uterus and surrounding structures. So here is the uterus, and here are fallopian tubes that connect to the uterus, and each fallopian tube leads to an ovary. Now, the ovary is responsible for ovulation. So ovulation is release of an ovum or an egg. Now, the ovary itself is not directly connected to the fallopian tube, but the fallopian tube essentially catches the ovulated egg. That ovulated egg enters into the fallopian tube, goes through the fallopian tube, and enters into the uterus. So the uterus is where an egg or an ovum that has become fertilized implants. And the area of implantation is the endometrium. That is the inner lining of the uterus. And that is what is affected in endometrial cancer. Now, below that endometrial layer is the myometrium. That is a muscular layer. Myo meaning muscle. That is responsible for the contraction of the uterus. And then the next layer of the uterus is what is known as the perimetrium. The perimetrium is continuous with the peritoneum. So that is another layer that surrounds the uterus. So before we go on, it's important to note a few other structures here and some of the other parts of the uterus. So the uterus can be broken down into a few different parts. Here is the fundus, the top of the uterus. This would be considered the body of the uterus or the corpus of the uterus. And then below that is the cervix. So this is the cervix here. And then below the cervix is the vagina. So these are some of the structures that can be involved in endometrial cancer, especially when there is spread of the endometrial cancer. Now, it's also important to understand the menstrual cycle to better understand why endometrial cancer occurs. So here is the endometrium and the thickness of the endometrium and the changes to the thickness of the endometrium throughout the menstrual cycle. So during menstruation, there is a decrease of endometrial tissue as that endometrium is sloughed off. And then in the first phase of the menstrual cycle, and an average menstrual cycle is 28 days long, the first phase is the follicular phase. This is a particular phase where there is some variation to how long the phase can last. So in an average individual, the follicular phase is going to be 14 days long. And then the next phase would be the luteal phase, which would be another 14 days. So there's an average of 28 days. But again, this phase can change depending on the individual. And we're going to talk about more about that in the next upcoming slides. So the follicular phase is dominated by estradiol, which is itself an estrogen. So the responsibility of estradiol, or this estrogen, is to increase the thickness of the endometrium. And at the end of the follicular phase, there is ovulation. And this leads to the generation of what is known as a corpus luteum, which then produces progesterone. So progesterone is what dominates in the luteal phase. And progesterone acts to inhibit the growth of this endometrium. So this is going to be important to understand what happens with endometrial hyperplasia, which is a growth of the endometrium, and eventual endometrial cancer. So again, in the follicular phase, which is the first half of the menstrual cycle before ovulation, is when estradiol, which is an estrogen, that's when estradiol actually leads to the thickening of the endometrium. After ovulation is the luteal phase, and that's when we see an increased level of progesterone, which inhibits or restrains the growth of the endometrium. So progesterone inhibits further growth of the endometrium. Knowing that, we can remember estrogen as something that grows things. You can think of it as something like a fertilizer that increases the growth. And in this analogy, we can think of it increasing the growth of grass. And progesterone being the lawnmower. This is a typical example that is used to help remember what estrogen and progesterone do. So you can imagine that if there is too much estrogen, and especially not enough progesterone or very little progesterone, you're going to get too much growth of the endometrium, too much endometrial thickening. And this can lead to what we call endometrial hyperplasia. Hyper meaning above or high, plasia referring to growth. So this is what can happen. And endometrial hyperplasia is actually one step in the process toward endometrial cancer. So an abnormal thickening of the endometrium, and this can be considered a premalignant thickening of the endometrium. So now that we know how the endometrium responds during the menstrual cycle and how it responds to both estrogen and progesterone, we're going to better understand why the following are risk factors. So the first risk factor is endometrial hyperplasia. We just mentioned that endometrial hyperplasia is an abnormal thickening of the endometrium, and this is essentially a premalignant thickening of the endometrium. So this is one step on the way toward endometrial cancer. Another risk factor is polycystic ovary syndrome or anovulation. So the reason that this is going to be a risk factor is because we just talked about the menstrual cycle, where in polycystic ovary syndrome and the condition of anovulation, there's not going to be ovulation. So no release of an egg. There's not going to be a transition into the luteal phase. Because there's not going to be a transition into the luteal phase, we're not going to get that progesterone. And that progesterone, again, acts like the lawnmower. It helps to restrain and inhibit the growth of the endometrium. So because of that anovulation that we see from polycystic ovary syndrome and other conditions, we're not going to have that progesterone. There's not going to be that progesterone around. And then another risk factor is hormone replacement therapy, especially hormone replacement therapy that is unbalanced, meaning that there is no progesterone with it. If it's just an estrogen-based hormone replacement therapy, then we're not going to have that progesterone to help balance or counteract the growth on the endometrium. Both of these are examples of unopposed estrogen. So again, we mentioned that progesterone will act to inhibit the growth of the endometrium. It acts to oppose the effects of estrogen. So in these examples that we just showed here, these are going to be risk factors that have to do with unopposed estrogen. Some other risk factors that can increase the risk of endometrial cancer include obesity and diabetes. The reason that these are risk factors is that diabetes is associated with obesity, and obesity has to do with increased adipose tissue or increased fat cells. Those fat cells actually convert precursors, steroid precursors, into estrogen. And again, that increased estrogen from those fat cells, that adipose tissue, is going to act on the endometrium. It's going to lead to thickening of the endometrium. So the patient is going to have more exposure to estrogen. Another risk factor is nulliparity. Nulliparity is not having any children or not giving birth. So the reason that this is the case is because you can imagine that you're going to have multiple menstrual cycles over the course of a lifetime, whereas if there were pregnancies, there would not be that menstrual cycle that the patient is experiencing over and over again. So that would reduce the amount of menstrual cycles that a patient experiences. Another risk factor for getting endometrial cancer is early menarche and or late menopause. So early menarche means the first onset of a period in a young female patient's life. So the first period, if it's early on in their life, that means that they're going to have multiple menstrual cycles throughout their life. They're going to be exposed to estrogen longer in their life. And related to this is late menopause. And in this definition, late menopause is greater than 52 to 55 years of age. And this too is going to prolong the patient's exposure to estrogen throughout their life. So early menarche and late menopause are both going to increase the span of time whereby a patient is exposed to estrogen. And that estrogen exposure, again, leads to the thickening of the endometrial lining or the endometrium and increases the risk for endometrial cancer. Increasing age is also another risk factor for endometrial cancer. Again, this all has to do with similar things we talked about before. Family history. So if there's a family history of endometrial cancer, you're more likely to also have it. There may be a genetic predisposition that runs in the family. Genetic conditions like Lynch syndrome, or also known as hereditary non-polyposis colorectal cancer. This is because there are DNA mismatch repair proteins that are mutated in this condition, and this increases the risk of not only endometrial cancer, but also other cancers as well. So this would be considered a familial cancer syndrome, so it also increases the risk of colon cancer. Other cancers can also increase the risk of endometrial cancer. So if there's a history of having certain types of cancer like ovarian granulosa cell tumors, breast cancer, or colon cancer, these can all increase estrogen levels. And as I mentioned before, estrogen is going to act on the endometrium to increase the thickness of the endometrium, increase the cell divisions of the endometrium, and essentially increase the risk of mutations occurring in the endometrium. And then tamoxifen use is also another risk factor. Tamoxifen is a chemotherapy used to treat breast cancer. It's anti-estrogenic in the breast tissue, but it's pro-estrogenic, or it acts to increase estrogen signaling in the uterus or in the endometrium. So that is the reason why we can see tamoxifen use being a risk factor in endometrial cancer. Now, along with these risk factors, there are certain things that can reduce the risk of endometrial cancer. Combined oral contraceptive use reduces the risk. So combined oral contraceptives have both estrogen and progesterone. So you may be wondering, okay, we're giving a patient estrogen, but the levels of estrogen in combined oral contraceptive pills are actually lower than those that would be exposed in a patient who is undergoing a menstrual cycle. And these pills also have progesterone, so that would be protective against the estrogenic effects on the endometrium. These are going to be especially important in patients who experience anovulation, so patients with polycystic ovary syndrome, for instance, or PCOS, and patients who are nulliparous. So these are going to help reduce the effects of each menstrual cycle, and especially in the cases of anovulation where there's no progesterone to counteract the estrogenic effect on the endometrium. Weight reduction is also important as well. We talked about adipose tissue, increasing the conversion of steroid precursors into estrogen. So because of decreased weight, that's going to decrease levels of estrogen, leading to decreased risk of endometrial thickening and endometrial cancer. Late menarche, early menopause, and multiparity are all things that will decrease the risk of endometrial cancer. So again, this all makes sense. Late menarche, early menopause are both going to shorten the time span whereby a patient experiences exposure to estrogen, and then multiparity does the same. After delivery of a baby, breastfeeding exclusively also reduces the risk as well, because the prolactin from breastfeeding helps to inhibit your menstrual cycles. So that is also going to reduce the estrogen exposure as well. And then, interestingly, smoking is associated with a reduced risk of endometrial cancer. So patients who smoke are actually at a reduced risk of endometrial cancer, although this would never be advised because smoking increases the risk of so many other types of cancer. But I also want to mention that here because this is an interesting educational point. And there is some hypothesis as to why this may be, but it may be that the smoking reduces the risk of endometrial cancer due to earlier onset of menopause. Now let's talk about the types of endometrial cancer. So endometrial cancer is separated into two types, type 1 and type 2. With regards to type 1, this is referred to as endometrioid adenocarcinoma. This is the most common type of endometrial cancer. Endometrioid because it resembles normal endometrial tissue. It's considered well differentiated and low grade. So well differentiated because it looks like endometrial tissue. As I mentioned before, it's the most common type of endometrial cancer, and it is responsive to estrogen. It is estrogen dependent. Because it acts like endometrial tissue, it responds to estrogen. So all of those risk factors we talked about before that increase estrogen and those that lead to unopposed estrogen are all going to increase the risk of type 1 endometrial cancer. Because it is well differentiated and low grade, it actually has a lower risk of mortality in this type of endometrial cancer. There are particular gene mutations that more commonly occur in endometrial cancer type 1. Those include the following: mutations in PTEN, KRAS, PIK3CA, PIK3R1, FGFR2, ARID1A, CTNNB1, and MLH1. So you don't have to remember all of these, but I would point out a few of them here. PTEN is an important one. KRAS, PIK3CA, and ARID1A are important ones. And MLH1, you can recognize that from Lynch syndrome. So PTEN here, you can see in some of these signaling pathways, here is the PI3K pathway, here is PTEN, and mutations in PTEN would lead to overactivation of some of these growth pathways. So if you want more information, if you're interested in the biochemistry behind these gene mutations, please check out my full lessons on some of these signaling pathways. And in endometrial cancer type 2, this is going to be a less common type. It's going to account for up to 10 to 15% of cases. And type 1, I didn't mention before, but it accounts for up to 80% of cases. Type 2 is going to be estrogen independent. So we talked about type 1 being dependent on estrogen. It responds to estrogen, but type 2 doesn't. It follows a different pathophysiological mechanism. This type of endometrial cancer is poorly differentiated. It is high grade, so it is going to be more aggressive in nature. And this leads to a poor prognosis. So oftentimes the 5-year survival rates for these patients with type 2 endometrial cancer are lower. But luckily, they are the minority of cases. But there are certain specific differences between type 1 and type 2 with regards to patient characteristics. So the patient characteristics in type 2 are going to be different than type 1, and these patients are oftentimes going to have particular characteristics, including vaginal atrophy. They're going to oftentimes be a thinner patient. They're going to be older, so they're oftentimes going to be 10 to 15 years older than a type 1 patient, and they're oftentimes going to be of African descent. And again, type 1 patients are going to be more often younger than type 2 patients, and they're going to be more commonly overweight or obese because that adipose tissue is going to increase the conversion to estrogen, which is going to increase the growth of the endometrial cancer. There are actually 2 types of endometrial cancer I'm going to talk about here in type 2. One is known as serous carcinoma, and the other one is clear cell carcinoma. Each of them have slightly different pathophysiological mechanisms. Serous carcinoma has particular gene mutations I want to mention here. These include TP53, HER2, so this is a receptor, PIK3CA, PTEN, and aneuploidy, which is multiple or more copies of chromosomes. So the one I want you to take away here is TP53. This is going to be an important gene mutation in serous carcinoma. And then with regards to clear cell carcinoma, it's not well defined, so we won't talk much more about clear cell carcinoma. Now let's talk about the signs and symptoms of endometrial cancer. By far the most important sign of endometrial cancer is abnormal uterine bleeding or abnormal bleeding from the vagina. And this bleeding is most oftentimes going to be painless. There's not going to be any associated pain. So you can imagine that if there is a growth in the endometrium, if the cancer is growing and it's utilizing a lot of blood, it can bleed, and that bleeding can enter into the vagina and be seen by the patient. There are going to be 2 important patient populations to distinguish here because they're going to have slightly different findings with regards to the abnormal uterine bleeding. The first group we're going to talk about are the premenopausal and perimenopausal patients. Premenopausal meaning before menopause, and perimenopausal meaning that they are still having their periods, but they are starting to get less and less heavy and less frequent because they're getting closer to menopause. So with regards to these patients, these premenopausal and perimenopausal patients, they're going to have either spotting or abnormal bleeding between menstrual cycles, which would be intermenstrual bleeding. And they may also have menorrhagia that may also occur as well, heavier menstrual bleeding. So it can be difficult to detect, especially in premenopausal patients. But what's important is that most of them are going to be seen in the perimenopausal period. And we mentioned that as a patient gets closer and closer to menopause, their periods are going to become less and less severe and less frequent until they have a complete cessation of menstruation or a complete cessation of their menstrual cycle, which means that they are in menopause. So what can be noted here is that when a patient is in the perimenopausal period, their periods can start to become less and less frequent and less severe. But if there is a case where there starts to become increasing frequency of menstruation or increasing frequency of abnormal uterine bleeding or bleeding, vaginal bleeding, and severity of bleeding, if the bleeding increases in severity as opposed to decreasing, which it should if they're in the perimenopausal period, that is going to be a key sign or key finding of endometrial cancer. That could be a sign of endometrial cancer, and that's something to recognize. And in the patients who are postmenopausal, after they've gone through menopause, which are going to account for the majority of patients. 75% of patients are postmenopausal. Any uterine bleeding at all, any bleeding from the vagina, which would be postmenopausal bleeding, is going to be a sign of endometrial cancer. It's going to be something that requires investigation. Now, having said all that, endometrial cancer is not the only cause of abnormal uterine bleeding. Abnormal uterine bleeding can come from other things like uterine polyps. So just because a patient sees abnormal uterine bleeding doesn't mean that they have endometrial cancer. It needs to be investigated. Other signs and symptoms include iron deficiency anemia and associated symptoms. You can imagine that if a patient's losing a lot of blood due to abnormal uterine bleeding, they're going to become iron deficient, and they're going to have iron deficiency anemia and associated symptoms like fatigue and other symptoms as well. And then in some patients, they may not even have abnormal uterine bleeding. They may have other more vague symptoms that are hard to recognize. Some of these include abdominal pain, bloating, and pelvic pressure. These findings are going to be more likely to occur in type 2. So type 1, you're going to see this abnormal uterine bleeding, and it's going to be, again, the most common type. It's going to occur in 80 to 85% of patients, but there may be a very small group of patients who have endometrial cancer that don't have abnormal uterine bleeding, but they have some of these other findings: abdominal pain, bloating, and pelvic pressure. And again, these are going to be more likely to occur in type 2 endometrial cancer. How do clinicians diagnose endometrial cancer? Oftentimes, they're going to do a pelvic examination. Oftentimes, there's not going to be much found. It's not going to be any gross evidence of disease in majority of cases. What's going to be most important to use is a transvaginal ultrasound, looking at the endometrial stripe, which is the thickness of the endometrium. If there is endometrial thickness at least 4 to 5 millimeters, that would be considered abnormal, and that would require further investigation. And if there's some question as to the measurement, some cases may warrant a hydroultrasonography to rule out false positives. But most patients are going to move on to an endometrial biopsy if there is some abnormality found on a transvaginal ultrasound. And this would include DNC, or dilatation and curettage, or a focal biopsy. With regards to the endometrial biopsy, if the patient is perimenopausal and they're having increasing frequency and increasing severity of menstruation, even though they should have the opposite of that, oftentimes a clinician is going to move to the endometrial biopsy right away. They're not going to do the transvaginal ultrasound because they're in the perimenopausal period. They're oftentimes going to have a thickening of the endometrium anyway. So oftentimes it's going to move on to the endometrial biopsy. With the biopsy, histopathology, so looking at the tissue under a microscope, is going to be important. And it's going to look for certain characteristics, including increased gland to stroma ratio. So if there's more glands in the tissue, that could be a sign of an abnormality. Atypia, so something atypical with the cells, and dysplasia of the cells are some important terms that can be noted with an abnormal finding on endometrial biopsy. If there is increased gland to stroma ratio or increased thickness of the endometrium without atypia, that would be considered endometrial hyperplasia. But again, we know that endometrial hyperplasia is important to deal with because that also is a pre-malignant thickening of the endometrium, meaning that if left, that can increase the chances of endometrial cancer. Certain laboratory investigations are going to be important, and this includes beta-HCG levels to rule out pregnancy. Now let's talk about the staging of endometrial cancer. The staging of endometrial cancer is by the FIGO staging. This is going to be the most important prognostic factor. So the lower the stage, the better the prognosis. Stage 1 is going to be confined to the corpus of the uterus. It's going to be confined to the uterus. And stage 1 is separated into stage 1A and 1B. 1A is where there is less than half of the myometrium invaded. We talked about that layer of the uterus, that muscular layer below or under the endometrium. So if less than half of that myometrium is invaded, that would be 1A. If at least half of the myometrium is invaded, that would be 1B. Stage 2 is where the cancer invades into the cervix, but there's still no extension beyond the uterus. So it goes lower into the cervix. Stage 3 is where the cancer has gone outside of the uterus, but it's confined to the true pelvis. So stage 3 is also broken down into 3A, which is serosa and uterine corpus invaded, 3B, which is where the vagina, perimetrium are involved, and 3C, which is where lymph nodes are involved. So 3C would be where pelvic and or para-aortic lymph node metastases are present. So it's local lymph nodes in 3C. And then stage 4 is where there is spread even further out into the bladder, in the bowel, for instance, or further distant metastases. So stage 4A would be where the bladder, bowel, or other structure is invaded. And 4B is where there's distant metastases. So there's distant cancer somewhere else in the body. So those are the stages of endometrial cancer. And again, most important prognostic factor is the stage of endometrial cancer. And again, type 1 endometrial cancer is oftentimes going to be identified in the lower stages, stage 1, whereas type 2 endometrial cancer is oftentimes going to be found in the later stages. So that's also another important point to note out as well. How do clinicians treat endometrial cancer? So treatment is going to involve surgery. There's a saying in medicine, goes along with many different types of cancer, and that is heal with steel. So healing with steel from steel instruments in surgery. So heal with steel, hysterectomy with bilateral salpingo-oophorectomy, or BSO. So total abdominal hysterectomy, TAH plus BSO, bilateral salpingo-oophorectomy is going to be the treatment of choice. So this is where there's going to be a removal of the uterus, removal of the fallopian tubes, which would be the salpingo part of this, bilateral, meaning both sides, bilateral salpingo again, the fallopian tubes, oophorectomy, removal of the ovaries. So removal of the uterus, removal of both fallopian tubes and both ovaries. That is going to be the treatment of choice. And then along with this are important pelvic washes as well. And then depending on the degree of spread, there may be some extra requirement of taking some dissection of a pelvic node or peri-aortic node dissection, or taking a part of the omentectomy or the whole omentectomy if there is any question as to whether there's invasion of some of these structures. In some cases, if there is a higher stage or a higher grade of cancer, adjuvant radiotherapy or chemotherapy can be important. If there's some question of recurrence of the disease, these are also important as well, especially chemotherapy. And there is a very large list of possible chemotherapy choices that can be utilized, but some of them include carboplatin, paclitaxel, cisplatin, and doxorubicin. Please look up some more information on the chemotherapies that are used if you want more information on this. And then in some cases, progestin therapy may be used, especially if in the case of endometrial hyperplasia. So if there hasn't been any atypia found, if there hasn't been any atypical histopathological finding, then this would be considered endometrial hyperplasia. But again, we know that this is pre-malignant. If this is left, this is going to increase the chances of having endometrial cancer. So progestin therapy can be utilized to help reduce or inhibit the further growth of the endometrium. But oftentimes, patients with endometrial hyperplasia, especially if they are in the postmenopausal period, they oftentimes also undergo a hysterectomy with bilateral salpingo-oophorectomy. So because there's still that risk of endometrial cancer, a lot of times clinicians will decide to go forward and remove the uterus and associated structures. And then after the surgery and treatment, it can be important to have follow-up using, in some cases, CA-125 measurements to assess for recurrence of the cancer. So if you want to learn more about other types of cancer, please check out my lessons on those topics. And if you haven't already, please like and subscribe for more lessons like this one. Thanks so much for watching, and I hope to see you next time.